Happy New Year, happy 2020. Can you believe it's here already? I can't. It's just so fast, it's amazing. So we're thrilled to be opening our Lunch and Learn with our CEO, Dr. Steve Barnett. He's a national speaker, and he's our president and CEO of McKenzie Health System, and he'll have a most informative update for us today, and you'll have flyers in front of you for everything that Dr. Barnett talks about. And our healthy lifestyle also starts up again in January. And January 27th at 5:30, we have Aaron Lipka talking to us about our cardiopulmonary rehab program. And that's exciting to learn about too. And then our healthy lifestyle in February will be on our New Year's resolutions with Kimberly Carell, one of our nurse practitioners, and the importance and some strategies of how to keep them. So I'd also like to introduce Tanya Mabey. She's always the person you register with, whether it's for Lunch and Learn or Healthy Lifestyle. And thank you again for coming, and with no further ado, Dr. Barnett.
Thanks. Thank you, Louise. Louise always gets us started in an upbeat sort of fashion, doesn't she? And when she's in the room and she laughs, everybody knows she's there, because nobody does it like Louise does. So I'm grateful that you came, and that not everybody traveled south. Of course, winter hasn't really hit yet, has it? Although driving in this morning, it felt like it, from 25 through Deckerville, and I think Colette and I agreed that once we get past Wadsworth Farms, it seems to clear out, and the snow quits falling. So what I'm going to review for you today, and some of this kind of fits well with the beginning of the year, and that is generally a review of those things that we do offer at McKenzie, but also a reminder of some of the things that we've been doing and why this all, or how this all fits together. To begin with, I wanted to at least review the fact that we do have a number of specialists, and usually what happens is you don't think about that until you need it. And then you may think, well, I need to call Port Huron or Saginaw or go down to Detroit, when in fact some of those services may already exist here. For those, and I think we've done a pretty good job of advertising or marketing with Gloria and Clear Ideas, but Dr. Robart is our general surgeon. He comes to us, and we worked with Hurley Medical Center in Flint in order to get him here. And he's been here probably 3 or 4 years now. Does a lot of general surgical work, including endoscopy procedures. For those of you that may have had a colonoscopy in the past with Dr. Nasser, we're all aware of that Dr. Nasser passed last year, unfortunately. And we've continued to provide those colonoscopy services, though, using our general surgeon, which is not an unusual thing to see when you go to other organizations as well. We've had Dr. Tom Wright, who's been coming here for years now from Genesis in Grand Blanc. He provides a clinic up here. He's an OB/GYN provider. He's been doing primarily GYN work up here. As you all know, we stopped providing OB services in 2007. That's not to say we don't like OB services, we do. And we would like to think that someday in the future we'd be able to get that back on board and offered here at McKenzie. Ophthalmology, Dr. Leone, so if anybody is in need of cataract surgery, I've been there and done that already, so I know what that's all about. But he comes up here every couple months, or a couple times a month, and provides that service, and we'll generally do those on a Thursday. Cardiology, we've really expanded. We've had Dr. Huffaker here for a number of years, and that's been a relationship that we struck with Covenant. They had brought Dr. Huffaker on at Covenant as part of their cardiology group with the intent of just putting him up here in the thumb. We've had some success with that relationship. However, we have found that Dr. Ketterpaul and Dr. Akhtar, which is part of the Ascension Medical Group, we added those two cardiologists, and they are working with St. Mary's in Saginaw primarily, although they do have access to any of the other cardiologists within the Ascension structure. We've had really good results with those two since they began, I think in August is when we started that up. So what does that mean to you? It means that you have a number of options when it comes to cardiology services, and we are seeing a lot of that work being done here in radiology for echo, stress tests, and the like, and these guys are doing a great job of turning the results around pretty quickly so that you're not wondering how all things turned out when you have that procedure done. We added Dr. Maluski a couple of years ago for ENT, so for kids you think of tonsils, adenoids, that sort of thing. We try not to do kids that are below the age of, keep forgetting if it's 2 or 4, but 2, thank you Patty. Just from an anesthesia standpoint, and part of my background is anesthesia, you can get into trouble with some kids at a very young age, so that's why we try to avoid that in terms of their breathing and then potentially having bronchospasms when they wake up. So once they get to the age or get over 2 and beyond, then it's pretty easily managed, and we're comfortable doing that here. And then for adults, if there's any septoplasty surgery, nasal and the like, ears, if you have any problems there, again, he's here a couple times a month as well. And he's out of Saginaw. It's an independent group in Saginaw. Orthopedic surgery, Dr. Kozier, we've had him here, I think, for about 4 or 5 years now. He came to us from the west side of the state, Grand Rapids area. He grew up, actually, in southeast Michigan in Royal Oak, and then he did his training in Kansas. He's done a really nice job. He does a lot of advanced work when it comes to scopes and orthopedic surgery. So, in fact, he can do a hip scope, which is something that not all orthopods are doing when you go to other areas. In fact, not sure that that's even done in Port Huron at this point. So we have a great orthopedic service that's available here. People need to take advantage of it. And then podiatry, most of you are familiar with Angie Stoutenberg. She works and lives up in Port Austin, but works out of Bad Axe primarily. But she does come down here and provide a clinic once or twice a month. And then, of course, and I got that wrong, it's not Theridan, it's Sheridan, sorry about that, right here in Sandusky, who, as you know, has been remodeling a building downtown, and we'll be moving in there very soon. I guess it looks really nice when you get inside. A lot of that work has been done recently. Dermatology, Dr. Roberts has been coming here again for a number of years, so there's no excuse to not get those potential melanomas checked and taken care of. And then pediatrics, most people don't know, but Dr. Gormley, although I know you know, is also certified in pediatrics. So we do have all those things covered, and happy to point that out. On the specialty side, we've been providing anesthesia services here, and although it seems from time to time there's been confusion, although not for anybody here, and certainly not for me or Nina, but we're not related. However, this one I am related to. Okay, that's my wife, and if you've been here for anesthesia services or any surgical procedures in the past, odds are you may have at one time or another had her providing your care. And then Mike McMillan and Jane Jacobson is from Sandusky, well, originally from Harbor Beach, but her and her husband have lived down here for some time. She's also an anesthetist, so those three have primarily been providing the anesthesia services here since I think 2004, at least for Mike and Barb. Dr. Hammond, most of you have seen or heard or have some experience with him. He's been our medical director for the ED, and it's a combination ED hospitalist program. And we put that into play several years ago because most primary care physicians that you may be trying to recruit to the area to provide services do not want to round on patients in the hospital anymore. So that old model of after the end of the day of seeing patients in the office, then you go to the hospital, they're not interested in that. They want that 9 to 5, 8 to 4:30 or something like that, and then go home and have a life. So in order to take care of those that are admitted to the hospital, we need to cover it, and typically that's being covered now by a specialty that's emerged over the last 1.5 decades, and that's called hospitalist service. So they're usually primary care providers who simply come in and round on patients in the hospital and manage that inpatient care. I think at first there was a lot of anxiety related to that because people wanted their physician, their primary care physician, to come in and see them. But once you've experienced this model, and you know that you've got a physician in-house around the clock, 24/7, 365, to manage anything that comes up, there's a lot of comfort associated with that, and we've had a lot of good luck as a result of putting that into play. Radiology has always been provided here, or at least for some years has been provided here through the radiology group that's been in Port Huron for forever, it seems like. That's an independent group. They cover Port Huron, McLaren, Port Huron, what was Mercy is now Lake Huron Medical Center at the south end of town, and then River District, which is just south of Port Huron, and they cover us. We do a lot of that using a system where the images, once they're taken here, they're stored on a computer. I'll keep it simple, not just for you, but for me as well. And those images then can be pulled up by the radiologist from Port Huron. So often we can get the results very quickly once the images have been taken here, whether it's a CT scan or just a standard X-ray or possibly some other films that may be done. Mammography is another great example of where we can turn those images around and get you results pretty quickly. And if you're in the emergency department, it's important because these guys are available, or somebody that they use is available around the clock. So if you come in, we need those images read very quickly. It's as if having them here all the time. That's how Dr. Ferentz is the medical director that covers us here. Swing bed program, I think most of you have heard about the program over the years. That's something that we were able to really develop and make it stronger once some of the legislation at the state level was changed to support it. And since then, we've had the program up and running. Dr. Hammond, who also serves as the medical director over the ED hospitalist program, that group and he also monitor and manage the swing bed program here. Cardiac and pulmonary rehab programs are two programs that we recently started in 2019. And as Louise pointed out, in a future Lunch and Learn, you'll be hearing about some of that. But suffice it to say that one of our primaries, Dr. Sams, who currently covers an office here in town as well as one in Peck, serves as a medical director for that. And for those of you that don't know, before Dr. Sams became a physician years ago, he was a registered respiratory therapist. So this is right up his alley, that he also understands the pulmonary and the cardiac rehab side of this service. We've been excited about getting that going. We've created a space down in the med-surg area that allows us to provide those exercise regimes and the program that's necessary to take somebody through the rehab process. And it also, what we're most happy about is it allows a lot of those patients that do have pulmonary problems, they typically find themselves somewhat socially isolated because often they're carrying around an oxygen tank or some device, and they may have a cannula in their nose in order to breathe in enriched oxygen, which makes it easier for them to breathe. So it's not unusual, and to Louisa's earlier introductory point, I do get out nationally, and I'm part of an advisory committee for the national, for the Rural Health and Human Services. And one of the things that we've looked at in North Carolina is pulmonary rehab and the processes associated with bringing that up and getting it going, and also the social isolation component. So we've found that these folks, when they interact with people who have similar devices and struggle with similar problems, both from a medication as well as an exercise routine, there's some comfort and some socialization that occurs with that as well. So we're happy to provide that. And then one of our most recent programs that Billy Joe, who's sitting over here and is the Chief Operating Officer, if you'd raise your hand for those that don't know you, she is also the person who has taken the program on for the substance use disorder, and that was a grant that was written last spring or summer, I forget which, but awarded in the summer. And what we're able to do is begin to develop a program that allows us to offer substance use disorders and medication-assisted therapy for those that are trying to recover. And so we're beginning to roll that program out now. It is grant funded, so we have 3 years of funding to get that up and doing well. And because of the relationship that we've had with the Ascension health system, we're able to tap into the Brighton Recovery Center, which is, I think, the second oldest recovery center in the nation. And it's allows us to use telemedicine technology to gain access to some of those services that they can provide to help us along the way as we develop and roll this program out. So we're very excited about being able to get at that population and provide them with some place to go if they're seriously considering beginning this process of recovery. Right now, Dr. Hammond, and I'm being generous when I say they're co-medical directors. It's really transitional. It'll be from Dr. Hammond over to Dr. English. He's stepped up and said, yeah, I can take that on and I'd be willing to do that. So we're very excited, and I know you had a meeting yesterday or the day before and had that group in and had some conversation about the process that's going to be rolling out, and I think the enthusiasm looks like it's there. And yeah. Yeah, cool. All right. So I've mentioned the term telemedicine, and again, I think many of you may know that we offer this service, but I just want to frame it in the context of just what it means to you and to others that are accessing care here at McKenzie. This is something that we developed in concert, or really as a result of the stroke network that we worked with the St. John Providence's Neuroscience Center of Excellence on in 2012. And so the technology that we use to connect that Neuroscience Center of Excellence and those neurosurgeons that exist down there to you here, if you access our emergency department with symptoms that you think may be stroke related, is we can look at they can look at you using this technology, a cart, we call it a robot, and they can evaluate your condition, they can provide us with some input, and then we can get things going that are going to prevent you from having any disabilities later on if we can get some of those drugs moving quickly. Sometimes they're called clot busters. You would think of it like that. And then we can get you to that center if there's anything else that needs to be done that's invasive. And then as soon as you can get back out and back here to your local community, we can continue with that process of working you through that rehab piece and without having to travel. So the telemedicine component is really the result of the stroke work and that development of a stroke network program that we got involved in years ago with them, that has become, well, we like to think that the care that's delivered is becoming a standard when it comes to when you're accessing care in an emergency department. And we can assure you that that standard is being met here, as I'll review in a few minutes. But what that allows us to do, and we're on our 3rd generation of technology, which doesn't include all the upgrades that go along with each level. Today, we're able to provide a number of specialists here to you that otherwise would not be something that they would come up here and open a clinic up and provide service for, because the population or the density of people that need that work is just not here, and it doesn't make a lot of sense. But this way it does. And again, I'll refer to Billy Joe because she plays a significant role in a lot of this. As you would expect, we've moved from across the street to a location right next to the pharmacy. Really, if you haven't been in there, you should go in. We cleaned that up, and it's really looking good. And now it's just telemedicine services that are in there. So it's really a virtual specialty clinic, and that's how we tend to think of it. Plus, it's a place where you can go after hours if you have that lump or bump or you think you have a cold, but you don't need to go to the emergency department. That's where you would go and access that service as well.
Is that where Dr. Ellis used to be?
Pardon me?
Dr. Ellis used to be, the new, Sheldon Pharmacy downtown.
Well, you're way back further than me.
It's talking about across from A, so okay.
Yeah, the Sanilac Pharmacy in town.
Yeah.
Yep. It has one entrance, but you can go 2 different ways once you get in there. So that after hours clinic is staffed by Christy Harms, which is a nurse practitioner that a lot of times, and this is interesting, you can go to our website and you'll see an example of it, where she'll be on the monitor talking to the patient that's come in over here at the after hours clinic. And so what we wanted to make sure as we designed and built this thing is the people that you would be seeing when you did log in, and we have staff there to help, obviously. You don't have to do anything. Just sit down and they'll get you all set up. But the staff you see on the monitor are staff that you know. They're part of our health care system. They're not just somebody from someplace in America, we think, who's logging on and taking care of your cold and really has no skin in whether or not you do well. So we're very happy with that. And then pulmonology, neurology, cardiology, behavioral health are all in varying degrees of startup. If they haven't already, behavioral health has. But cardiology, as an example, is something that because Dr. Ketterpaul and Akhtar, the 2 cardiologists that I mentioned earlier, who are from St. Mary's and Saginaw and part of the Ascension Medical Group, because they're part of that system, we're able to use the same technology across their organizations. And so they'll be able to log in here. And what this means is that after hours, if you come into the emergency department, those physicians there can pull up somebody who has a specialty and consult them as if they were here. So that's really adds a whole nother layer of service at a specialty level, whether you're coming in through the hospital or going specifically for those things that you might need over at the after hour or virtual clinic. So we're very happy with the way that's evolving, and we believe it's going to continue to evolve. Just as a side note, there have been some organizations, and what comes to mind in particular is in South Dakota, where they've actually built out a group of specialists who sit in a warehouse, for lack of a better example. But inside of that warehouse, you have nurses and physicians monitoring patients in a whole variety of different locations, and it's referred to as a virtual intensive care unit. And what some of the studies have shown is because of that level of monitoring, so they're just focused on you the whole time you're in there and the stuff that's coming across on the screen. It's even been stated that it's likely they're going to catch something before it progresses very far because of that constant monitoring. So there might actually be an added benefit to having a virtual ICU than having the old traditional one because of the level and the intensity of monitoring that goes with it. Something we're not doing yet, but certainly not outside the realm of consideration for us to engage in the future. Primary care providers, I'm sure you probably are familiar with all of them. All of the providers that you may or may not be familiar with already at McKenzie. And you do have some of this stuff that is in front of you that can outline that for you. And I would encourage you to take it with you. So all those specialists that I already reviewed are on here, as well as our primary care providers. And what I want to highlight about the primary care component is that we have, in rural America, primary care really is the specialty that you see being provided by hospitals like this that are all across the country providing service at a local level. And primary care, when you think about where healthcare is going, is really a specialty service that has probably been underrated historically. I say that because not everyone will access care in a hospital. So you may or may not ever need to go to a hospital to see a physician. So there will never be a record in a hospital of what's wrong with you or what your condition was at that point in time. However, today, everybody, and we're encouraging this, should have a primary care provider. So if you don't already, then you should consider linking up, and I would obviously recommend one of ours locally. But what that primary care provider does is they have a thorough history of you. They understand who you are. They understand what your conditions are. They understand what your meds are, what labs have been done. And that is part of an electronic health record that presumably will be able to be mobile. And if you go out of state or you go someplace else, we'd like you to be able to access that. And today we have some ability for you to come in through a portal if you have a record with one of our primary care providers and see some of the activities that are going on with you. So lab results might be sitting there as an example. So what's most important about having established that relationship with a primary care provider is that now you have a medical home, and that's what we call them. And what that does is it allows that primary care provider to be your consultant. So if you think you've got something going on with a hip or a knee, or you're feeling your heart doesn't feel right, they ought to be able to at least point you towards somebody who has a specialty that's going to do a great job working with you because they know who they are and they know how what level of work they provide. And they can also make sure that that communication about your condition, once you go to see them, is sent back to them so they have it in your electronic health record. So if you then went to Florida and you ended up in an ER as an example, and you needed to see what's going on with the last visits you had, it's possible in the future that we'll be able to, you'll be able to pull that record up, and that physician down there can see what your history is and what meds you're on and all of that. So that's where we'd like to see this go in the future, and that's why we'd like to see all of you with a primary care provider, and in particular one at McKenzie. So trying to think what I had next on that slide. Some of the things that I did want to cover had to do with the services that you don't traditionally think of, but are really the result of the activities from being in an accountable care organization. One of the things that we did back in 2014 is co-founded that organization with some folks in California and Indiana. We were the only critical access hospital in Michigan. And at that point in time, and then flashing forward, we're probably one of the leaders in terms of having experience in managing populations. And the population we're managing is a Medicare population locally, and we're trying to manage you to wellness and only provide services that add value. So what we've demonstrated, and one way to measure that is how are we reducing the cost to Medicare for the lives, the Medicare lives that are assigned to us. And what we discovered in 2017 and in 2018, once CMS, the Center for Medicare and Medicaid Service in Washington, reconciled our work from that year, they share with us then how much money we did save on the lives that are assigned to our ACO. So what we were dealing with were 8 organizations like us in one ACO, and we had 10,000, I'm going to make it simple, we had 10,000 lives. Each of us have to do the work, and we have to reach out and touch those lives that are assigned to us. At the end of the year, what we saw is we reduced Medicare's cost on that population by $5.8 or $5.9 million. That's just doing some of the things that I'm encouraging people to do with primary care and why you need to have a primary care provider. And seeking services locally from efficient providers, right? So in 2018, we saw that reduction continue. So our performance in that last year was 4.2, 4.6, give or take $500,000, right? The point is, over a 3-year period, we reduced the cost on that population by $10 million. And half of that is taxpayer savings, and half of it comes to us, or not McKenzie, but shared among the providers that made that happen. So by working you towards wellness and you doing things that add value to your health, we're able to actually reduce costs, and we've got more experience at doing that because of what we did in 2014 and all the work that we've been doing since than anybody else. So when you access primary care through our organization, you can be sure that we're working on wellness and value rather than the old model of sickness and how many things can we do to you to get paid, right? The current one, the one that we're in right now, happens to be, and again, they're called ACOs, Accountable Care Organizations. So the one that we're now in has 129 communities like us. We're in 22 states and Guam, and right now we're on track with 230,000 lives of saving about $93 million. So it's just crazy how what happens when we begin to engage with people and actually get them to participate in their own health and begin to take an active role. And that's a change in behavior and culture from us on the healthcare provider side, because that's not what we always did, right? We just told you what you needed and expected you to go do it, right? And that just doesn't work anymore. And it never really did, quite frankly, which is why healthcare costs became out of control. So you're in the midst of pioneer work in the Accountable Care Organization arena. We've spoke about that. Billy Joe just came back in December from Phoenix at a meeting where there were, 600 or 700 people who want to learn about what we started with 8 other organizations in 2014. So this isn't about bragging as much as it's about informing you so that you take pride in the small hospital in your community and what it's doing, not only on a state and local level, but at a national level. The other things that we've done, and I'm going to go through a quick list because this has transpired over the last 5 or 6 years as well. And the woman sitting next to Billy Joe is Patty Schafsnetz, and she's our director of nursing, and she's been very active in the things that I'm about to list. And without her work and coordination of activities throughout the organization, some of these things would not have happened. So I'll begin with, it doesn't matter when, because we're coming up for recertification, but 3 years ago, we were the first critical access hospital, which is what we are, in Michigan to be fully certified as a level 4 trauma facility. What that means to you is that we're providing a level of care that meets that minimum standard for trauma. And those standards are evidence-based work in the research world that makes sure, and then we're certified, so we know that we're providing that minimum level. I would tell you we're going well beyond that, but certainly at the minimum level. So we're the first hospital to be level 4 trauma certified. That wasn't enough because we started working with the stroke network development with Ascension Health, and that has been adopted both throughout the state for Ascension Health facilities and nationally because they have a national footprint. And so what we did is we then said, well, we should probably be surveyed and certified as stroke ready. And so we're the only critical access hospital in the state of Michigan that has gone through that process and is deemed a stroke ready facility. So if you come in here, they're saying that we're going to be able to take care of you, certainly at that minimum level, but we believe that we go way beyond that. Our most recent certification was how we manage people who have heart attacks. We've had some great results because we coordinate care across EMS to us to a receiving facility that has a cath lab if you need an invasive procedure. All that coordination of care results in you getting the best outcome, meaning your heart gets blood flow and is opened up and there's no damage, so there's no deficits after that acute episode. So what we did is certified with Joint Commission on Accreditation and became the first Michigan critical access hospital to be deemed certified as acute heart attack ready. And I think we're either the second or the third one nationally, critical access hospital to be certified and approved as acute heart attack ready. One thing that has not become a standard, like the 3 that I've just identified, or we think they will become standards for everybody, we've just made them our standards already, is a program that Dr. Hammond, our ED hospitalist medical director, wanted to launch a few years ago. We did so in 2013, called an oxy-free ED, which means when you come into our emergency department, if you have pain, we're not just going to give you narcotics and send you on your way so that you can go to the next emergency department if you have a substance use disorder problem and get more prescriptions and more pain pills. So what we started to do is limit that and then begin to engage in a conversation about, is this really pain or is it some other problem that we need to think about and talk about and get you connected contractually with one of our primary care providers so that we can begin to help you get beyond this. And so that oxy-free ED program that we started here in 2013, it was, I think, 2 years ago that everybody in America realized that we have an opioid crisis, right? Now, we all know that it didn't happen 2 years ago. It happened a lot longer ago than that. But it became recognized as a significant issue. And so now everybody's trying to scramble to get something done and address this problem. We'd already been doing it. And no one else, we couldn't get anybody else in the state to join in on that and do it as well. Now everybody wants to know, how did you do that? What are the statistics that go with it? How has it been performing? And so that's another example of how you'll see McKenzie on a national level outlining the program that we developed years ago here, so others can implement it in their own emergency departments. Curiously and incidentally, the emergency departments of the hospitals in the Colorado Hospital Association 2 years ago or 3 years ago came together, and I found out about it 6 months ago, but they put together a program and launched it in 18 that does exactly what we did in 13. Yeah, they're getting all kinds of press over it. Yeah, we were way out in front of them and couldn't get anybody to do it. But they approached it the right way. They got their hospital association behind it, and they're really implementing and doing the things that we've been doing for years. So it's just another example of the innovation and the need to change and deliver care at the highest level that you have right in your backyard. The last thing I would say is that all those pieces that I just described, one other certification was the geriatric ED. We went through that. Now we're a geriatric ED certified by the American College of Emergency Room Physicians. We did that actually a year ago. So that's another first. There were no others, level 3 in the state. So all of those things represent what we call systems of care. And those are, that system of care model is what's evolving, and it's evolving at a pace that you typically see government programs evolve at. Very, very, very slow. And rather than waiting for that to happen and really waiting for them to decide how it should work and what it should look like, what we've been doing is taking that on and really charting the path forward and getting it done as we speak. So I can't think of a better organization to be involved with than the one that I'm involved with here. And the staff that you have in this facility, many facilities have a problem attracting nurses or physicians. We have a waiting list of nurses trying to get in here because of what we're doing. And it's that kind of thing that really attracts those highest level of performers. And so that's really what I'm trying to tell you, you have access to here. The other things that you, if you're ever in this facility, you may see is we have students ranging from, what's the thing in the school system that we have here?
X-ray.
The what?
Laboratory.
Lab, X-ray.
Physician.
Medical assistants, yeah. So the kids from the high school, the Career Center, thank you. We get a boatload of those through here throughout the year. Then we have nursing students from a wide variety of programs across the state that will do rotations. They may be working here as a student. We have physical therapy students who will be working here doing clinical rotations. We have med school students from Central Michigan, University of Central Michigan's med school, and they'll do rotations here. They've been in the primary care offices for several years now. We have a relationship with Michigan State University's School of Human Medicine, which is the MD side, and they can do elective rotations through our ED hospitalist program because it's unique and it's something that they want exposure to. And we're looking at right now and engaged in conversations with the new dean at the College of Osteopathic Medicine at MSU for having elective rotations and potentially starting up some rural rotations, because that's how you attract physicians back to communities, is if they can come here and get that experience and see what's going on and they like it, they may come back. And that cuts away or erodes the shortage issues that we've always dealt with. So a lot of good things going on at McKenzie, and I hope you guys talk about us when you're out there and tell others that you've got a really, really, really well-connected, great hospital, and we partner with organizations that we think deliver the highest level of care, which is why we've done a lot of work with Ascension Health and the various facilities that they're associated with. So I will take any questions if you have any, and if I can't answer them, I'm sure that Patty or Billy Joe can. Anything?
Wonderful. I think you should do more bragging though, so the whole community knows how far ahead.
If I could get you with that drawl to talk like that on the radio, I'm sure they'd listen. No, we you know, it's always a mystery why. Sometimes I'll go to a club meeting, and I'm asked, why didn't we know about your swing bed program? And I'm just going, oh. We've been on the radio, we've been in the local papers, we've been on these things. I mean, we've done everything but walk it into everyone's house and hand it to you. It really goes back to my initial comment, and that is you don't think about this stuff till you need it, right? And so, unfortunately, we're one of those things that just exists inside of a community, and you don't, you know, the old thing, you don't miss the water till the well runs dry. Well, that's what we're trying to avert. One thing I didn't speak to, but I will right now, I'm reminded of, is since 2010, there's about 1,300 of critical access hospitals across the country. Since 2010, and that's of the 6,000 hospitals that exist, so since 2010, 118 of them have closed because they were not supported or they weren't doing the things, they weren't innovating like we are here. So it can happen. And a recent consulting report out of New York by a company called Navigant last year reported that there are 430 hospitals across the country, that's 1 in 5, that are financially stressed and at risk of closing. So in Michigan, there are 18 rural hospitals that are financially at risk of closure. And we know of one that did close several years ago up in Sheboygan. That was the only one recently. The point of this is that when these little hospitals close, they're gone. The feds, the state, nobody's going to come back and say, okay, we need you, let's start you back up again. Once they're gone, they're gone. And that's what we're trying to prevent from happening. We know that having health care as a presence in your community is important. Most people don't recognize how important it is till they need the care. If you look at it from an economic driver, we add both in terms of direct and indirect revenue into the local community in the neighborhood of $20 or $30 million a year. And in Sanilac County, I think it's $86 million when you add the other 2 hospitals that exist into that. So that's a significant local economic driver in addition to providing health care. And so we don't want to lose that. We know that we need to perform well. And that's why we're doing all the things that we've been doing since 2010 and the passage of the Affordable Care Act, is to make sure that we transition this organization in such a way that we're going to perform at the highest level regardless of how healthcare is financed. So if I take that out of the equation and just focus on how do we deliver the best care possible, and yeah, we got to get paid to do it, but we're doing it in a conscientious economical model. What we're really doing is advancing how we deliver care and changing how we deliver care from a decades-old model of just being here, waiting for you to come in sick, is not what we do anymore. We haven't been doing it for a long time. Many organizations in this state, which is why 18 are at stress, they haven't made that transition, and they don't even know how to make that transition. We're always fascinated with some of the questions that we get, because the question really tells you just how far behind they are. And so obviously I'm very proud of what the people here at McKenzie have accomplished, and so I hope that you're able to take some of that pride and spread it around the community as well. Any other thoughts or questions?
Thank you very much, Dr.
Thank you.
Barnett.